Hello and welcome along to this conversation about anticipatory care planning, organised by Say Something Dundee. My name's Helen McGregor and I'm on the working group for Say Something Dundee. Today I am joined by Jacqueline Thompson. Jacqueline is the nurse consultant for older people with the Dundee Health and Social Care Partnership. Would you like to introduce yourself and just give us a little bit of background?
Oh, thank you, Helen. So I have been a registered nurse for rapidly approaching 27 years now, and I have worked in older people's services specifically since 2006. However, I was appointed to a nurse consultant role for older people in Dundee in 2014. And it's also important to add that I'm a human being as well. I'm not just a nurse consultant, I'm also a mother, a sister and a daughter, and until last spring I was a granddaughter, and indeed held some of these conversations with my own grandmother. So I do have not only a professional perspective to bring to that, but a very personal experience of conducting these conversations with my own grandmother as she was moving towards the end of her life.
Okay, oh, that's really kind of you to share a little bit of personal insight. So I have got some guide questions to start us off, but I wondered if you could maybe, to get things going, give us an idea of who anticipatory care planning is for and kind of what it is, I guess.
So I much prefer using the phraseology a thinking ahead document.
Okay.
I feel that's more meaningful. Anticipatory care planning is widely understood within sort of healthcare professional and social care circles. When I am opening up a conversation around about anticipatory care planning, my own preference is to use the phraseology of this is a thinking ahead plan or document, and I think that strikes a chord more meaningfully with people than using our somewhat jargonized title.
Yes. Okay.
And nevertheless, the essence of an anticipatory care plan, again, some of it's alluded to in the title, is we are anticipating that something may happen that might not be pleasant or optimistic. And so it's us having a conversation and a discussion round about, well, what if this was to happen? What is it you would or wouldn't want to wish happen to you in terms of your future health? And anticipatory care plans are for everybody. Ideally, they should be for all adults. They shouldn't just be exclusive to older people. And they really become of particular relevance with the growth in our population in Scotland of people living with long-term conditions. Many long-term conditions are sadly incurable. So they are progressive. We cannot cure them. We can control some of the symptoms. So in essence, another phrase I use is, so we can do things that will hold back the tide. That's the metaphor that I'll use. So these drugs, these treatments are holding back the tide, but they're not going to prevent the tide from coming in.
Okay.
Ultimately. So there is a progressive nature in many of our long-term conditions. Of those I can think of are heart failure, chronic pulmonary disease, advanced renal disease, some of the liver diseases. So a great deal of these conditions that people are living with in the wider population have a progressive declining nature over the course of time.
Yeah.
And so those trajectories need to be understood, and that there will be points potentially of crisis within these trajectories, and it's about having an understanding of, well, if this was to happen, what may or may you not like to have happen to you.
Okay.
So it's about having an understanding.
Conversations you have with your family are the bit that I am more kind of comfortable with, but in terms of actually you're dealing with healthcare professionals, who would you do the planning with, and who instigates the conversations? Like, can you phone your GP up and say, I've had this diagnosis, I'm ready to chat, or how does that all work?
So for me, it's about who feels the right trusted healthcare professional that you feel is appropriate to have this conversation with, that has the knowledge and the skills to also help guide and inform you in some of the decisions that you're making. So yes, by all means, that can be a GP. I would be doubtful that these conversations could be achieved within the mandatory 10-minute slot.
Yeah.
So where families are wishing to have these conversations with the GP, I would suggest and advise that they request the possibility of a double appointment. So it's a 20-minute slot, and that's more commonly at the end of the working day for a GP, the other trusted healthcare professional. So people who have long-term conditions may well have a very longitudinal relationship with a specialist nurse.
Okay.
And that might feel the right fit.
Okay.
To have this conversation with.
And which way does it normally go? Is it normally that the nurse would be the one that would bring this conversation up, or can you take charge of the situation and kind of bring it up yourself?
So it's great when people do bring it up on their own volition, but Helen, that's not often the case.
Okay.
It does happen that people have been mulling it over and they've been thinking about it, and they've acknowledged this and they want to talk about it.
Mm-hmm.
However, in my many years of experience, that voluntary action is in the minority. So the conversation often starts with seeking an understanding of what that person is aware of within their own health conditions. Because in the instances where we're initiating it as healthcare professionals, we don't do this lightly. It's often because we have a real professional concern about something serious is going to happen. And we have our concerns that perhaps that person hasn't had the time with other healthcare professionals to fully have explained and shared to them the severity of the stages of their underlying healthcare conditions.
Okay.
And where we're at and what that might mean. So where we're opening that up, it's often coming from a place of seeking an understanding of where somebody's at, about understanding the severity of their usually many underlying health conditions.
Okay.
And then it's multifaceted. So the anticipatory care plan is like the banner, and then there's the spokes off that header.
Okay.
So encompassed within an anticipatory care plan, we as I've suggested earlier, we not only like to ask about, well, what would you or wouldn't you like to have happen to you moving forward? Now, this is individualistic and depends on what healthcare conditions you have, how advanced that is, and whether we are reaching a point where medical treatment isn't going to be helpful, and we could be transitioning into this end of life phase. So that may be conversations about, would you like to go into hospital? What conditions, what circumstances would you wish to go into hospital? And on occasions we may be quite explicit and direct about that as healthcare professionals.
Okay.
So we may be quite direct about, so for example, you have worsening chronic obstructive pulmonary disease. That's a disease of the lungs. We've noticed that you're having more and more recurrent chest infections coming closer and closer together. And whilst we've done well recently, we've managed to keep you at home. Your infections have been successfully managed at home with antibiotic tablets and steroids. But what if you had another infection which might be coming your way soon, given this pattern we're seeing, and the antibiotic tablets weren't working? The next natural step up would be intravenous drug therapy antibiotics, because they're more potent, they're only available in hospital. Would you or wouldn't you wish us to admit you to hospital? These are sort of the scenarios we play out, because and the reason we're doing that is it's not intended to cause undue distress or anxiety, but these what if conversations, if we're doing them when somebody's not ill and severely ill and in a severe crisis, are much easier to have. Now, of course, they're not set in stone. None of these decisions are legally binding. So that person might say to me, do you know what, Jacqueline, if this was to happen to me, I wouldn't want to go into hospital. I just want to take my chances at home, and that would be that. And we would document to that effect. But things in life are fluid, and so that person may change their mind in that moment when that event happens to them, and go, actually no, this is not for me at home, and actually I actually do want to go into hospital. So it's just to give a reassurance that anticipate some of the facets of an anticipatory care planning are not set in stone and are not legally binding. They're an indication of what you would or you wouldn't like to have happen to you, but they're really useful for us as healthcare professionals when we're entering into a sudden health or mental health crisis, and we've got some handle on. Last time we talked about this, is that what you still want, or actually are you sitting somewhere differently?
And would that question always be asked at the time as well?
Well, it should be. I mean, I can't speak for everybody, but yes, it should be re-explored. Or if the medical professionals feel that hospital admission really, really isn't in your best interest, that should be discussed and explored at that moment in time as well. And why they're thinking and they're feeling that. So that's all part of should be part of a shared decision-making process.
Okay.
You know, when we're making choices about, you know, do we go into hospital for treatment or not, should be ideally a shared decision.
Okay, that makes sense. That makes
so that's
sense.
but
Okay.
that is but one element of an anticipated care plan. But there are other facets which are legally binding and do not change. It's really important that we talk about how multifaceted it is, because this will come up, that this may well come up in an anticipatory care planning discussion. So the one side of it is, you know, what would you or wouldn't you like to have happen to you in the future should these events possibly happen? It should also include who would you like to advocate for you? And advocacy is a really, really important facet. So who would be your loved ones that you would want to be your spokesperson? There is independent advocacy services available within Dundee City that may not be widely known within the population, but as healthcare professionals, that's a service I'm aware of, and that may be appropriate to suggest advocacy and an independent advocate to some people when we're having these anticipatory conversations.
Okay.
Or I would urge all adults to consider having what's known as a legal proxy or a power of attorney.
Okay, back to the anticipatory care planning. Within that bit of it, you would be asking the questions, have you got this piece of paperwork and this piece of paperwork? You wouldn't necessarily go into depth.
Have you got power of attorney? If it's no, have you considered that? You know,
yeah.
I would have to say for anybody that's over 65 that's on my caseload, I would say, well, I recommend this.
Yes.
For anybody that's over 65.
Yeah.
And would you like some information about this?
Okay.
I mean, it's voluntary, but that's how I would tend to play that out. You know, if it hasn't been appointed, would you like to consider it? I would recommend it. Here's some information. Would you like information?
Perfect. Yeah. Okay, that's good.
I mean, we kind of reflect that anticipatory care plans mirror a lot of birth plans. So I did a birth plan with my midwife as a new mother, never having laboured before, and you know, you got your dream birth plan.
Yes.
The reality is there's uncertainty. Nobody truly knows what's going to happen when you go into birth. So you may have this, I would like this, but sometimes reality, and you need a bit of open-mindedness about things can change. And sort of in the same way, when we're thinking about what would we or wouldn't we want to have happen to us as we move towards the end of our life, has some similarities and parallels. So I will personalise this. So my hierarchy of preference for where I would wish to end my life, you know, I would like to end my life in my own home. And if that isn't possible, my preference would be, if at all possible, a hospice setting. Hospice, care home, you know, so I would have my own, and that's helpful for people to know that. But sometimes the reality is that as much as we try to support end-of-life care at home, sometimes that isn't something that's possible, and it's actually in your best interest that we put you into another environment. So it's about it's great to have some thoughts and some thinking about where you would like end-of-life care to be, with that little caveat of just be open to not being totally fixed on, you know,
Yes.
Like a birth, I'm going to have a natural birth and I want it with whale music and in a pool, and then, you know, other events happen and you have a...
Yeah.
Do you know what I mean? So because
yeah, of
really
course.
predict it's, and as healthcare professionals, you know, we absolutely want to honour somebody's wishes and preferences about where they wish to end their life, and you know, we really do move, you know, mountains to make that happen at home. However, we just recognise our limitations, that sometimes it's not. So it's great if you've already had those thoughts and got some ideas. That's fantastic for you to share, but a bit like any of the anticipatory care planning discussion, it's rare for somebody to actually come and go, do you know what, I've thought about my end of life care plan, and
yes. What difference do you think having an anticipatory care plan in place can make to, well, I was going to say to the individual, but to all concerned, to the healthcare professionals, the individual and the family of the individual? What difference does it make?
It means we're not making decisions on your behalf, which might be not what you would ever have wished, and particularly when we're discussing its relevance towards the end of life. So important that we know, and as I've already expressed, we want to honour what your wishes are, and if we don't know what they are, there's a risk that something will happen to you that, you know, we didn't know about. And what's really heartbreaking is to have conversations with family members and loved ones when an older person is moving towards the end of their life, and they're bewildered, they're not really certain about, I don't know if mum or dad would have wanted this, and they're trying to fumble about in their grief about, because they've not held that conversation, so they don't know how to navigate, and so it's in a time of their own grief and distress, they haven't got clarity. So it's about that, helping us as healthcare professionals and as loved ones that might be speaking on your behalf when you can't. So it's very much rooted in honouring somebody's wishes and desires.
A lot of the ACP stuff covers off what matters to me. That's really the kind of core principle behind it. If us could share a one what matters to me to get people into the mindset of maybe going away after they've watched this and having a conversation with a loved one.
So there's a mantra about no decision about me without me. So wherever possible, I want to be involved in my decisions, even if they're not pretty ones. I would like healthcare professionals that are able to hold courageous conversations with me, help me balance up pros and cons, and respect my decision, even if it isn't one that they would have chosen. So there's something about, for me, about my autonomy and being empowered to make a shared decision-making process wherever I am in the system, be that GP surgery, community, outpatients, or in hospital. And please don't give me instant coffee.
Totally with you on that.
I need 2 cups of high octane, freshly ground coffee in a cafetiere. Otherwise, I don't function. Thank you.
Excellent. So all that remains is to say thank you for watching to those who are watching, and also really a massive thank you to you, Jacqueline. I think you've raised my confidence levels in terms of having these conversations